I will talk about everyone's. Yes, I'll talk about a lot of stuff. Laminar not fused in the cervical region, spinolaminar line, ventral interlaminar line, contralateral oblique view, seated position, and contrast spread techniques. This topic about visualization. It's about knowledge. You definitely want to see this monster in your side mirror. So I picked up this article for some important issues. First, they found that there is a big chance that while performing this procedure blindly, you'll end up nowhere. What doctors did, they put the needle in the cerebral region and then they inject the dye and see where actually dye went. And more than 50% of cases, they saw it goes in the soft tissues, not into the epidural space. It's understandable that the spread of the dye goes on one side because there is a plica mediana, and in more than 50%, when you inject on one side, it's not going to go on the other side. So it's important to do injection on the side of the lesion. The average spread of the contrast was more than 3 levels with the low volume of the contrast, 2 ml. And that's goes against most people practice. They inject high volumes, 4, 5, 6 ml. And there is no need for this. You just inject low volume, but at the level of the problem. And it's well known that the higher the needle size, easier to feel loss of resistance. Okay, this is a study of Flick, and everyone referred to this study. It actually shows that more than 50% of the cases there is a ligamentum flavum not fused in the midline. And there is a risk of going to the epidural space without feeling loss of resistance. But how significant is it? It was the only study. It was a low sample study, only 50 cadavers. And if you see the mean width of the gap, it's 1 millimeter. So what they consider a gap? Sometimes it's probably not existing, sometimes it's big. And this is how it looks. This one works. Yeah, this is the gap, and this is no gap. It's very important to understand that the width of the epidural space is very small at the cervical region. It's 1 millimeter at C5, C6 level, when it's 5, 6 millimeters at lumbar level. And ligamentum flavum at the epidural space gets progressively thinner away from the midline. So you want to be safe, go by midline. You want to have adventure, go away from midline. A few lines. This line number 3, they call it spinolaminar line. It outlines spinal processes. This, by the way, George line, it outlines posterior vertebral bodies. A spinal cord, the epidural space in between. This is a Boston Scientific, 16-week Boston Scientific wire placed at the posterior epidural space. It actually shows spinolaminar line. The same wire but placed in the spinal cord. But is it? It's actually anterior epidural space. It's the same patient. I reposition it, place it properly. Okay, there are a few techniques how to do cerebral epidural injection. This is one that I found the most easy and straightforward. It's called touching the lamina. Basically, you put a needle on the lamina from below, and you touch the bone, and you redirect your needle in the epidural space. Nothing can be easier. You can see needle goes to the epidural space, and then without confirming the needle depth, you inject the dye and see this patch spread. And when you see the patch spread, I'm more than sure it's possibly it's epidural spread. Here I confirm it. I use a contralateral oblique fluoroscopy, and I see epidural spread, and also patch spread at the site of the injection. Okay, some history. I presented this topic last year and I made this video. The idea of this video was to explain some difficult issues with the help of light and shadow. Fluoroscopy is very similar to light, and it goes through the objects the same as light. And it's difficult to explain how different the needle positioning in regards to the midline, and how different fluoroscopy position, like rotation-wise along the needle, change the image on the screen. And I made this video, but being perfectionist, I didn't like it, so I keep working on it. And after certain repetition, I came to the version that I like more or less. I put it on YouTube, and I didn't stop. I wrote an article and published it in Pain Medicine. I used a different model this year, but I still hope it's better. Sorry. Anyone can help me with the count? Yes. You see? So simple. I'm going to use this bottle to describe different fluoroscopy. Bottle represents a model for ventral space. Ventral space is the space that outlines the spinal canal. It includes epidural space, dura, spinal cord, and all the layers. Remember CR. It has an X-ray tube, image intensifier, and monitors. I'm going to simulate something like this here. My phone is going to be a light source or X-ray tube. The wall is going to be image intensifier, and shadow on the wall is going to be a picture that you get on your monitor. Positioning my light source right in the middle will give me AP view. Rotating it 90 degrees from AP will give me lateral view. Something in between AP and lateral is oblique view. Line that we see at the back of the monitor is the middle line. It is an analog of a spinolaminal line. With the rotation of my light source, I see the shadow on the wall changes. Each time it reflects different edge of the model. As we call the model the ventral space, each edge of the ventral space is a ventral line. So I can say that edge of the shadow reflects different ventral line. For example, when I position my light source in lateral view, edge of the shadow will reflect a middle line. In this case, ventral line overlap middle line. With one needle approaching ventral space from one side and light source rotated towards the middle, I get a shadow on the opposite side of the wall. In case of fluoroscopy, X-ray tube moves towards the needle and image intensifier away from the needle. We call it the contralateral oblique view. If light source rotated on opposite side, I get shadow on the side of the needle placement. In case of fluoroscopy, X-ray tube away from needle, image intensifier on the side of the needle. We call it ipsilateral oblique view. Now we're going to go through three different situations. Situation number one, my needle approaching midline. Number two, it goes away from the midline on the side of needle placement. And situation number three, it goes away from midline on opposite side. let's see what happens. With one needle approaching midline and positioning the light so straighten the lateral view, you can see a needle tip touching middle line or edge of the shadow. When I go for contralateral oblique view, I can see my needle deep inside the shadow. With sedation number 2, when my needle tip away from midline with lateral view, I can see my needle deep inside the shadow. So with contralateral oblique, on the other hand, I can see my needle tip touching the edge of the shadow. And with sedation number 3, when my needle bypasses the midline, and rotating the light source as the needle half, but not needle tip, I can see my needle tip both with the lateral and oblique view. But is it a true contralateral oblique view? And the answer is no. To get true contralateral oblique view, I have to go on the opposite side, and in this case I can see my needle tip touching the edge of the shadow. To conclude, light and shadow model can simulate fluoroscopy and can be used to describe different fluoroscopy views. So it was fun. Okay, now I'll talk about contralateral oblique fluoroscopy and how I can use this technique to do injections. By the way, this is a typical patient in US. Patient has stimulated, patient has hardware placed. However, spinal cord stimulator was removed later because it didn't work. Patient still needs cervical injection. So it's similar with the initial approach. You introduce a needle from paramedial approach, and needle looks for the midline. Then you rotate Siam for contralateral oblique view. You usually get contralateral oblique view with rotation of the Siam 52 to 55 degrees. You can see needle approaching ventral interlaminar line. Needle keep approaching the ventral line. It's still safe. It's not preferred one through. It's very close. I didn't get loss of resistance, so I know I'm not. I always confirm needle positioning. I want to be as close to midline as possible because this is my safety area. Dye injected, and you can see the spread, the epidural spread of the contrast. And I confirm this spread with the lateral fluoroscopy, and it's very difficult to see. That's why contralateral oblique has a lot of advantages, especially with the prone placement of the patient. This is also typical patient for US. You can see Siam rotated for contralateral oblique fluoroscopy. Needle goes from the right to the left. X-ray tube rotated towards the needle, and the images fly away from the needle. Neurosurgeon wrote to me, extensive disc presents with facet arthropathy and spondylopathy. Too much for surgery to address. Needle approaching midline. Oops, I went through the spinal cord. But actually did I? The only way to know is to have a three-dimensional view. So you have to know AP, lateral, and oblique views. So this is AP view, and you can see the needle went from one side to another side. It's situation 3 in the video. So after a lot of struggle, I repositioned my needle. And this is epidural spread with contralateral oblique fluoroscopy. Here is some articles that you can read on the issue. They were published in Medicine 2012-2013. I'll talk about seated fluoroscopy, and I'll explain why I prefer to do procedures in the sitting position. It is easier to bend or extend the neck in sitting position compared to prone position. And this is why. You can see the model not bended, and here it's bended. You can see how beautiful the spaces are compared to here. It's easier to introduce a needle. It is easier to get shoulders out of the view with the sitting position compared to a prone position. Here, patient in the prone position, and you can see shoulders obstruct the view up to C2. Here is the same patient but sitting, and you can see as low as C7. Contrary to common belief, it is safer as compared to prone position. You can see I don't look for easy patients. Imagine this patient in the prone position, stop breathing, and I have to turn him around. I will die together with him. Here I just remove the needle and I put him, oh, now it works. I just remove the needle and put him on the table. Okay, this is the device I use for doing procedures in the sitting position. It's called fluorarm. It has frame that attached to the table. It has an arm. It's actually flexible. It can be flexible to any body size and form. And this is a carbon fiber covered with some foam for comfort. Carbon fiber is radiolucent, so it doesn't obstruct the view. I'm sorry. Okay, I'm sitting, demonstrating how I position my patient. And this is the way I save it. I mean, it doesn't take any room, and it's just stored by the table. Sure enough, I have two patents on the issue. And here I demonstrate how I do this procedure in the sitting position with the fluorarm. Needle goes from paramedial approach, goes to the epidural space. I went for lateral fluoroscopy. Needle keep advancing till it comes close to spinolaminar line here. I always confirm AP view to make sure that I'm not away from the midline. I inject the dye, and here you can see that there is some dye that's not in the epidural space, it's soft tissue spread. It's working. Okay, and now you can see epidural spread. Here you can see needle deep in spinal space. But is it really deep? So as we mentioned before, you have to know AP, lateral oblique. So, sorry. So this is AP view, and you can see that the needle is away from the midline. That's why it's moved deep on lateral fluoroscopy. And this is so-called ventral spread. It's not intrathecal spread. It's just a spread on the side of needle placement. Yes. Next two slides, surgeons are not going to like me. This is one of the patients that came to me with numbness, weakness, and sharp pain down his left arm. It was a father of neurologist who usually sends patients to me. And you can see there is a dye spread above and below the level of the trouble. The patient has a big C5, C6 herniation. This is the same patient, but after third cervical epidural, and you can see nice. So yes, bulging disc can shrink, and by the time he has this injection, he didn't have any numbness or weakness in his hand, but he did have some pain in the neck. Okay, this is the reason I'm here. This is the reason I decided to repeat this topic this year. It's called contrast spread technique. How many people in the audience use loss of resistance technique? Okay. How many people in the audience use a contrast spread technique? Few. And basically, it's much more common than you can imagine. A lot of us use this technique, we just don't recognize it. When we use loss of resistance techniques, we depend on tactile sensation. you have to feel this dramatic change in pressure. But for a few reasons, it's not reliable in the cervical spine. Ligamentum flavum is not fused. Epidural space is skinned. Ligamentum flavum is skinned. So it's easy to miss it. And the consequences are too high. You can get paralyzed or even dead. So why not use something more reliable? Why not to use our visual abilities? So it's easy to show it and to explain it. Here's my needle. It's approaching the spinolaminar line. So when you're close to spinolaminar line, what you do, you inject the dye and see the spread. Here you can see the spread. It's a so-called soft tissue spread. It's definitely not a epidural spread. So while one needle, very little, like 1 millimeter, maybe less, you inject that and see the spread. Here you can see a dramatic spread. A dramatic, it's an epidural spread, and it's a big difference compared to soft tissue spread. This is the same technique, but I use different fluoroscopy technique, contralateral oblique. Similar idea. You put the needle close to spinolaminar line or ventrolaminar line. You inject the dye and you see the spread. And here it can be either beyond the ventrolaminar line, epidural spread, or above it. That's a soft tissue spread. And clearly it is a soft tissue spread. Advance it a little bit and get an epidural spread. For the last 3 months, I don't use loss of resistance syringe. I just use a fluoroscopy to confirm epidural spread. I don't think it's optimal. I think optimal is to use both techniques. What I'll recommend to draw some dye in loss of resistance syringe, and while advancing needle, inject the dye and see the spread. And you will confirm epidural positioning of the needle with loss of resistance and with the counter spread technique. It increases safety. It's also increases efficiency because you're not going to miss it. And that's the conclusion of my presentation. Any questions? By the way, there are two articles. One is published and that one is pending. You can get it by Sierra.
Thank you very much.
What gauge needle are you using to do these?
It doesn't matter. When you use contrast spread technique, you can use 22, 20 gauge. I usually use 20 gauge.
Thank you. Well, what do you think about the aiding drop technique for cervical?
It's excellent when performed properly, but it's dangerous. I don't do it. I want to visualize the contrast spread. I want to be sure that it goes to the close.
There is a new piece of kit. One of my colleagues from the Far East was telling, it comes with a little balloon at the end of your epidural needle. Have you used it? Have you used it?
We have tried it, but we stopped it after several
Did you? Okay. I only heard about it very effectively.
Very critically reviewed.
No, I mean, I only heard about it. Basically, when you put it in the epidural space, the balloon just collapses and
you use it in the lower region.
Right. So, can I just ask you something? What about, there are quite a lot of pain clinicians, particularly junior pain clinicians, who are not very happy doing anything above sort of C7. And one of the things I've suggested to them was, why don't you put your needle at T12 or even T23, big in the laminar space, thread a catheter prop.
It's a good idea. It's done frequently. But the idea beyond my needle placement is you have to put needle as close to lesion as possible. You can do the same with the catheter. It's more labor
True. No.
with the catheter than with the needle.
Any questions?
So have you noticed in your practice that if you do more like a targeted and transforaminal or extraforaminal, the problem is about the C5, C6 level, so you do more targeted nerve root block, then cervical epidural. So what is your balance in between? Because I guess if it's a multi-level changes, probably you do cervical epidural. If it's just a single, or 2 levels, you will just go for the more targeted. Is it you practice?
I used to do cervical transforaminals, but I stopped doing it for several reasons. I'll have another topic this afternoon, and I'll explain why. I think it's safer to do cervical epidurals compared to cervical transforaminals.
Margaret and Chris.
Very good presentation, excellent X-ray images. I use the lateral, with patients in the lateral position. Have you got any experience with that before?
With lateral positioning, no, I don't, because I sit my patients. I found the patient feel more comfortable, and I actually get better fluoroscopy views. I do lateral position when I do C2, C3 middle branch plus, but not for cervical epidural. Still, shoulders going outside the view.
Yes, I mean in the lateral position you do have to make sure that the down shoulder is well.
The shoulder is the major issue. That's why I see the patient.
Chris said that, Andres.
I agree with you about the loss of resistance and contrast spread. I tend to use loss of resistance to air and contrast. So my question is, if you're using loss of resistance with contrast, I use a 22 gauge needle. How defined is your endpoint for the loss of resistance for anyone viscosity with contrast?
It's not reliable. I mean, I'm excellent with my loss of resistance. I give thousands of this, and still I get very nervous when I do cervicals only with loss of resistance. I want to see. That's why I talk about contrast correction. When you do the picture and you see it's not in the epidural space, you're not in the epidural space. So you advance the needle and you inject it, and you see what's going on.
Andres.
Just what is your monitoring when you do a patient in the sitting position? Do you put an IV cannula? Do you do sort of like
Always.
basic?
I always start the patient for cervical. I always put IV and make sure that the fluids are running. Sometimes I put pulse oximeters.
And any incident of the vasovagal symptom?
Happen.
Because
It happens
when
on
it's
several occasions. I just remove the needle and place patient supinous. You saw it. It's simple to do it.
Can I just make a question to Andres here? You mentioned about transforaminal cervical epidurals and any sort of acute radicular pain. Most of them settle down within a month or two without any treatment, other than medications.
Well,
But I mean, this is not my opinion. I mean, this is what is published.
but then you don't see this patient with a month of symptoms ever, and the patient.
True. True.
So, so you will see them after 6 months or longer.
Yes. So
Also, you see them after surgery. Or
correct. So the underlying pathology which you are injecting is already gone in 6 months' time.
Why if not?
No, it's usually gone. I mean, that's the whole thing. I mean, the bulging disc is no longer there.
That's why neurologist doesn't like to send patients to pain management, because
So this is my question. And so why don't we just do a cervical epidural, which is inherently safer than a transforaminal? It's just argument's sake, not questioning.
Because I was, during my talk, I was pointing out that doing the extra foraminal, because you don't stick your needle into the foramen, and then you may have a similar response, and then you save that.
True.
No, we take the extra, name it extra foraminal, not transforaminal.
Okay, fine. That's better. Thank you very much. Thank you very much. Breakfast time.